My name is Andrew Currie. I'm based out of Atlanta, Georgia. I've been practicing for 15 years, and I've been with Implant Pathway for 3 years at this point. What sparked my passion for dental implantology was a combination of a few things. For one, while I was in dental school, we were actually the very first class at the University of Louisville that ever actually had a dental implant specific class. Like they formed it while I was there to kind of show you how old I am. That was way more interesting to me than all the basic fillings and crowns and partial dentures and things that we had worked on at that point. A light bulb went off in my mind from a business perspective that my entire arc of my career would match in tandem with the baby boomer generation kind of aging their golden years, which is when people are losing teeth at their fastest. And it was one of the more successful generations. So there's going to be a lot of disposable income on folks that need teeth. Part of it was just me trying to be forward thinking as far as what a good business decision would be for my career. But it just so happened that the moment I got into it at all, I was like, I don't think I can go back to general dentistry. Like, this is so cool and life changing. And, it's hard to find anybody that can change a life by doing fillings. It's hard to find somebody that's not changing lives who's doing implants. And I want to do stuff on a high enough level that I feel like I'm making an impact in people's lives, not just taking care of, cavities. What made me want to become a instructor at Pathway and a mentor there, like what called to me, I was really fortunate in that I had been working with BioHorizons on a number of things, and Justin Moody, CEO and founder of Implant Pathway, he's big involvement with bio, and he had reached out to BioHorizons and said, like, is there anybody out there that I don't know that I should know? I had been doing some teaching for Pathway at the time. I'm sorry, for BioHorizons at the time, and they came by my office and were like, hey, do you know who Justin Moody is? Like, kind of by reputation a little bit, not super familiar. And he's like, well, would you be interested in teaching implant stuff? And I was like, I already do that. I do that at my old residency. I do that in a variety of ways. And so he's like, well, he's got a course in Atlanta, which is where I live, this coming week. Can I set up a dinner with you guys? And I was like, sure, I'd love to meet him. Just at a minimum, I'm always looking to meet movers and shakers in our industry, and he's certainly one of those. As soon as we met, man, we hit it off. Like, Moody's my people. And that goes for the entire Pathway tribe, because he's done a remarkable job of finding people that are our kind of people. And what I mean by that, in that dinner, Stephen Vorholt was there, a handful of people were there that have been longtime major Pathway people. And very quickly, it was evident to me that these people, like-minded individuals looking to level up just day-to-day dentists that are tired of being day-to-day dentists. And I feel like that's exactly where my brain has always been. I'm like, I'm a general dentist by definition, but man, I don't want to be one by daily trade, Moody said something at that dinner that immediately resonated with me, which is kind of how I think of how I evaluate people. He's like, I don't want anybody working at Pathway who I wouldn't let work on myself or my family members. And I also don't want them working there if I wouldn't like to go have a beer with them. And I was like, 100%. He's like, we literally do not allow people to enter with egos. Like, if you have an ego, you are not welcome here. And that has come up. He has reiterated that time and time again. And that's something that really jumps out at me, because I really try to live my life with as little ego as possible, but also trying to be as altruistic as possible. And I feel like those are the two main underlying currents there of let's help everybody. There's enough to go around. Like, there's no scarcity mindset. There's no jealousy. There's no competition. It's purely just looking at each other forwardly, just giving whatever gems that each of us have, casting pearls to each other, because everybody there is a really impressive individual, and we all learn from each other constantly, and nobody claims to be the smartest in the room, although I'm never that guy. It's like, it's a really cool room to be in when they're just like-minded, giving, brilliant, talented individuals. And it's like, put me on that boat. Like, that's where I want to live. I don't like the idea of going into a new job and having a boss, and so going there, I don't feel like I have a boss, because I feel like this is just how I do it every day. I just finally have a room full of people that I get to elevate, as opposed to like the one random person that's over my shoulder, or me just talking to my assistant or whatever. Every day that Pathway is out there doing their thing, there are a bunch of attendees whose career kind of canon, the trajectory has just cranked up a little bit to fire whatever their cannonball career shot will be, will go higher and further. The earlier in your career you make those adjustments, the more people you're going to help on a higher level for forever. That's so rewarding. It's kind of one of those, like, give a man a fish, he'll eat for a day, teach a man to fish, he'll eat for a lifetime. And it's like, we're teaching people how to fish and how to catch really big fish every day out there. And it's a really rewarding thing to know that we're sending folks home better than they were when they arrived, and know that they'll just kind of never regress beyond what you've just elevated them to. When I'm lecturing about sinus lifts, we talk about partial dentures a lot, because if you're missing your upper back teeth, you don't have any options other than a partial denture, which hasn't changed much since the Civil War. Like literally getting a partial denture made in 1860 versus now, it looks kind of the same. They're made of kind of the same stuff. It's kind of bizarre that like we really haven't done much in that realm. Or you can do bilateral sinus lifts and put in 4 implants and give them 6 teeth back on 2 sets of bridges and have them just go back to having teeth and chewing well and whatever. And if you're a clinician that is not trained in sinus lifts and implants, the best you can do is 1800s dentistry. The moment that you learn how to do a sinus lift, you've now opened the door to that patient having, even if it's an over partial, meaning like a partial that clicks into some implants, that is dramatically different than 1800s dentistry. That's some 2000 stuff right there. And if we actually have screwed in teeth or cemented in bridges, it's just like getting your natural teeth back, you know? The biggest thing I hope that they gain is that they go home and every time that they're presenting treatment or thinking about treatment for a patient, they're thinking about 2025 dentistry, not 1860 dentistry, you know? And it's like, you owe it to patients to tell them what the best thing is out there, whether you offer it or not. I firmly believe if you can't do it, someone down the street can, and it's a bummer to lose business to them, but I feel like it's an absolute disservice to your patient if you don't admit that thing's out there and you don't know how to do it. But, you know, these people are people. They're humans. We should be taking care of them, not taking care of ourselves and our paycheck. We shouldn't be having a scarcity mindset that I would rather take the $2,500 from this guy and give him an 1880 partial versus the guy down the street can get $25,000 because he's doing bilateral sinus lifts and bridges. Like, send it down the street, change that person's life, you know, or better, go take a course at Implant Pathway, learn how to do it yourself, have way more fun and make more money and do better dentistry, you know? So I'm hoping they're going home and thinking at the tip top of what dentistry can offer every time, you know? That's what I feel like we should be kind of ethically obligated to do as clinicians. So how the lateral wall sinus lift is considered the gold standard and how it improves longevity and success over time is because there's kind of only 2 options to growing bone in the sinus. And you can access the sinus either from a vertical or crestal approach, meaning kind of through the mouth by way of where the tooth used to be, or from the side or laterally. The lateral approach, or the Caldwell-Luck approach is what that's called, the vertical being a Summers technique. Basically, with a vertical approach, you can at most gain about 4 millimeters of bone predictably. Don't get me wrong, all of us, we've all had our miraculous cases where we've gained like 8, but that's like not what you should advertise as a thing, because that came as a surprise to every one of us that ever did it. We're like, ooh, I got away with one on that. I shouldn't have tried for that much, you know? It should be a 3 millimeter or fewer kind of thing, because that's very predictable for most people. But 4 millimeters, after 4 millimeters, even the best surgeons in the world are kind of tossing a coin. It's a blind procedure, so you can't really tell how you're doing until after you're done and you take a post-op CT. And at that point, it's either good or it's bad, and it's too late if it's bad, kind of thing. And so if you max out at 4 millimeters, you know, most dental implants that are worth a darn for if we're doing a sinus lift, that means we're in the posterior maxilla, which are your largest teeth. Your maxillary first and second molars are the largest teeth we've got. So we want a adequate sized implant to support the largest tooth that's involved in 90% of chewing or so. So you're going to want something sizable. And if you're doing a vertical lift and you can only gain about 4, that means you better have at least 4 or so to get an 8 millimeter, which is about as small as anybody kind of should be putting a molar on. Most of us want 10 or 12 or sometimes more. 10 to 12 is pretty standard, but if you're at 10 to 12, that means you've got 8 millimeters of residual bone, most likely. And at that point, that's pretty rare. You know, like if you're talking sinus lift, it's usually because you're missing enough that you actually need more than 4 millimeters. And at that point, once you decide to go lateral, once you have direct lateral access, it is not a blind procedure. You're looking at it directly and you can control the whole space. And the sinus is huge. And so that means we can add as much bone as we want in a responsible manner, obviously, in the sense of like, you can easily add enough bone to put in a 15 millimeter, 18 millimeter implant if you felt so inclined. That's typical and more than is necessary, but you have that option. And when you have that option, it means you can control kind of the whole space, the volume in all directions. You can do more than one tooth at a time quite easily. Because you kind of write your own maximum ticket, you're obviously going to have more options, more backup plans. Like even if I do a 15 millimeter lift and it shrinks down to 12, I've still got 12 or 10 or whatever. I can do a lot in there. If you do a vertical one and you get 4, it might shrink down a little bit and you get 2. And it's like, well, that wasn't that helpful. And just the fact that it's direct and you can see it and you can access it means that the success rate's very high. The complication risk for the blind vertical approach is also pretty high because you don't know. And so if you don't know, success rates can't possibly be as good as when you do know, And so, yeah, you can control your space. It can be a large graft quite safely and quite easily. And it's just, you can kind of write your own ticket. So all of those just give you control that the other ones don't. One of my oldest cases of all time, I did it back when I was in residency, but I remember the conversation with this lady very, very distinctly, where I met her where she was wearing complete dentures, and when she took them out of her mouth, they were like that thick with just layer after layer after layer of this weird series of relines. And I was like, what am I even seeing here? I've been out of dental school for like 4 months at this point. And I'm just sitting there like, who makes a denture that's 3 inches thick? That's bizarre and disgusting, honestly, with the look of it. And she's like, well, 25 years ago, people told me that there was no chance that I could ever have anything but a denture, and my bone keeps going further and further away. And so they just keep adding more relines to this denture, and I'm kind of tired of it. But she takes them out and like her ridges are just flat. I can see like why they keep just relining it, because there's literally no ridge to work with. I'm in a surgical residency. That's, what we do here. Let's take a CT scan, and just sinuses are massive. She's got no room for implants anywhere. Her anterior maxilla is pretty much gone. Her lower was down to what we call a chin strap. Like literally the bone was just like this thin little strap where the nerves were at the crest of the ridge, meaning like every time she wore her denture, it gave her like a burning sensation and everything. So the lady was in distress a little bit, in the sense of like she had a terrible daily tooth existence. She'd been living that, or some version of that, for 25 years. And she wasn't that old. So she was like, she's got a lot of runway left to just deal with that kind of a mouth every day. It's just kind of a life sentence kind of thing. So I ended up doing bilateral sinus lifts on her. It's kind of a rare treatment plan, but I did bilateral sinus lifts on her. And then I did a series of 3 implants and 3 implants with small bars. And I made what's called a bar overdenture, where it snaps into place. And I gave her, I got 4 implants right here in her little chin strap. I was very afraid I was going to break her jaw that day, but I did not. And they all healed beautifully. And we got a bar denture down there. And so that lady went from, 3 inches of goop sliding around with a burning sensation every time she tried to chew, to where you could grab her teeth and shake her whole head around, and she'd just be like, this is the greatest thing ever. Like, you can't get my dentures out of my face, where she could just chew whatever she wants. That was literally 15 years ago. And she reached out to my office maybe like a year and a half ago, where she had tracked me down. She lives in Texas now. And she had reached out to me just to let me know. She was like, hey, I just needed to find out like brand and like size of the implants. I was like, oh no, is everything okay? What's going on? She's like, no, I'm still doing great. My dentures are just 15 years old, and I'm making a new set of, teeth kind of thing. But like the implants are rocking and rolling, and you've completely changed my life. And it's just awesome to have gotten a follow-up heads up from a lady back from literally like my first few months out of school, telling me that, the last 15 years of her life had been so much better because we met, and this is like, that's a life change by way of sinus lifts. So sinus lifts help attract patients and differentiate you in your local market, because although I personally believe it's one of the most approachable surgeries for anybody that's in the surgical game. I'm not saying that you have to be an oral surgeon. In fact, I'm saying you don't. But if you're placing implants, if you're taking out wisdom teeth, if you're doing GBR, onlay bone grafts, if you're doing soft tissue graft, if you're doing any of that, each of those things I think is more highly demanding as far as surgical control of your hands and knowing what you're doing. All of that I find more demanding than a sinus lift. So a lot of people, they have all of the fundamentals required. They just haven't been taught about sinus lifts. The sinus in general, when you're in dental school, it's treated as like this mysterious, like the floor is lava kind of thing. Like if anything touches the sinus, you are going to get sued. You're in trouble. It's going to fail. They're going to have all these crazy issues that you don't know how to manage. Like they scare you away from it in a number of different ways. But then the moment you get exposed to people that do mess with the sinus every day, it's like all of those stigmas and fears and concerns and reputations or whatever become more like rumors almost. They're like, what were y'all talking about? Like, this is actually the most successful bone graft that we do in dentistry. And it's away from almost every like vital structure. You like kind of almost can't kill a person doing a sinus lift. You absolutely could kill a person taking out a wisdom tooth or putting in a lower implant, or there's all sorts of dangerous stuff that we do daily, not thinking of it as that big of a deal. When sinus lifts, that's not it. If you find out how many people around you are doing implants, I guarantee you a very small percentage of those people are also actually doing sinus lifts. To be a guy that or a doc that can do sinus lifts, that's way cooler than being an implant doc, because if you're doing sinus lifts, the only reason to do them is if you're also an implant doc. Plenty of people are going to go out and learn small amounts of stuff to do very basic implants, and therefore they will advertise that they do implants, but they'll do like the slam dunk stuff. And I'm not saying that's a bad thing. In fact, it's great and important to stay in your lane where you like in your comfort safety zone, but they're not getting sinus exposure during basic implant courses. They shouldn't. That's a level 2 thing for sure, but it's only because you need to understand where implants should go so that you put the bone and the sinus in the right spot. You know what I mean? Like it's not that it's a level 2 as far as demand goes. It's just like it doesn't make sense to learn that before you learn implants, because like if you can grow bone but you can't put the implant in, like most people think kind of only oral surgeons do, like specialists do them. If people are willing to have an implant placed by a GP, the first teeth lost or the most commonly teeth lost are maxillary posterior teeth. And it's like, if you want to be the doc on the street that's doing implants, that's a major percentage of the ones that are going to need doing. And then like, if you have to refer out for a number 3 with a sinus lift, the next time that person breaks number 22, they're probably going to go back to whoever had done their previous implant because that went well and whatever else. And so like you just will continue to lose people out your door to whoever you'd referred them to for the sinus stuff. So just, stop sending people out the door. Just learn the procedure that's very learnable. Complications are going to be a part of any kind of surgery. And so during the sinus course, we talk a lot about complications, and it's a common fear for attendees or people new to surgery or sinus surgery about what can happen, how do we manage it, how do we contain the graft, how do we just deal with any kind of complication. And a very important slide in my presentation, and a very important phrase that I reiterate numerous times through the didactic portion, is that the tear is coming. Just embrace it. It's just part of the procedure. The Schneiderian membrane is the membrane inside the sinus, and it can be like tissue paper, where it can be very, very, very hard to not tear, much less easy to tear. I mean, sometimes it's almost unavoidable. And so people are like, well, what are you going to do if you tear? And I'm like, I'm going to celebrate if I don't tear. That's Michael Picos is like one of the kind of, he's not the founding father, but he's kind of the modern day proselytizer, I suppose. Like he's taught so many generations of us how to do sinus lifts, and most of us are doing at least some version of kind of what Picos has been preaching for 30 years. And he'll tell you, a guy that's done probably thousands and thousands of these at every level, he's like, I tear more than half of the time. And it's like, okay, receive that. Like if that guy tears half the time, do you have any reason to think that you won't? Like just no. Like we all are going to tear them. It's just part of the procedure. And once you realize that, it's like, what are you going to do if the root canal isn't patent? And it's like, make it patent. Like it's part of the procedure. It's just the next step. Like y'all are just scared of that because you haven't ever done it before. We spend a lot of time talking about how to manage them because I don't even think you should label a tear as a complication, although it certainly is the most common one. It's so common that it shouldn't be considered a complication. It's just a part of the procedure. So we really try to equip them with the confidence and just kind of methodical steps of trying to manage it, to minimize it, control it, and contain it in a variety of ways. And there are a variety of ways, and we teach, and that are one size does not fit all. It depends on what the tear is, where it is, the size of it, and the accessibility of it, and where it is in proximity to what you're doing. It's just part of it. It's like, what do you teach them about complication? Or like, how do you teach them about management? It's like, same way I teach them about how to just do the dang thing. Like, you gotta, like, here's how you do your incision. Here's how you do your window. Here's how you mix your bone. Here's how you fix the membrane when you've torn it. Here's how you pack them. It's just part of the thing. It's not even like a different section. It's just part of the thing. Probably the number one thing that I teach in my courses to have people go home, differentiate themselves, level up their whole practice, grow, do bigger, better things, Honestly, it just comes down to fundamentals. One time I went to a cooking class and there were like 8 stations set out, and it was the exact same ingredients at all 8 stations. And the instructor went around and made each of us use the exact same ingredients in slightly different ratios at slightly different times. And we ended up making, it was all like pasta carb based, but in those 8 groups, we had like 3 kinds of pasta and 5 distinctly different kinds of bread. And it was just kind of like a whoa, like from the same bowl of stuff, like 5 ingredients or whatever, I'm making fettuccine or focaccia. And it's like, if you can have the fundamentals of surgery and just rearrange them, you can do almost any kind of oral surgery. We've always got to cut the gums. We've always got to suture them back. We got to know our dental anatomy. We got to be able to drill a hole in bone. We got to be able to manipulate soft tissue. We got to be able to X, Y, and Z. It's not, here's the steps to do 1 implant. Once you've learned that thing, like, what do we do if there's 2 implants? What do we do if there's a bone graft? It's like, no. Here's the flour. Here's the baking soda. Here's the olive oil. Here's the whatever. Assemble them differently this time. Assemble them differently this time. Assemble them differently that time. What do we have? We have a sinus lift. We have an implant. We have a bone graft. We've learned how to make proper flap design, how to release the periosteum, how to pack bone, how to create stabilization, how to, so on and so forth. So just giving them the ingredients that they can reassemble in an infinite number of situations that allows them to cook up whatever the day's menu requires. So when people get trained in surgery and they're worried about going home and kind of overtaxing themselves in their office by trying to add that in, my immediate response and reaction to that is like, that's just not how it's going to work. Meaning, if you actually want to do surgery, which you obviously are interested enough to come take this course, and hopefully after having taken this course, you do want to go home and implement it. I would say that very, very high percentage of all Implant Pathway attendees do in fact do that, because I hear from them a lot, and I hear their success stories. But basically, when you go back home and you now can place an implant when you couldn't the month before, it shouldn't be a thing that stresses your schedule. It should be a thing that relieves your schedule. Meaning, if you're doing 1 implant, the national average is probably around $2,000 or so for an implant. That's like without sedation or without bone graft or whatever. So the average filling is probably like $200. I was like, okay, so you were a filling dentist last week and now you're an implant and filling dentist this week. So do 1 implant and clear out 10 fillings worth of stuff from your schedule, which should be way more time than you need for the single implant. And in the beginning, maybe you use all that time because you're nervous and it's your first one. Like, fine, it's a push because it was 10 fillings worth of revenue in the exact same amount of time. Then it shouldn't have mattered business-wise, and it shouldn't have taxed your schedule at all because you're not worried about doing anything else. You're doing 1 long implant procedure. As you do a few of those, you'll find that you can actually do a lot of implant procedures in the same amount of time that you would do 10 or 20 fillings. Also, you'll hate life as you're doing your 20 fillings and it sucks. Whereas if you do your 2 implants, that's a very low-key day that made the same thing as 20 different appointments. Like, just at a minimum of going to 2 setups, even if it's a more elaborate setup for your assistants, like setting up for surgery is probably more involved than most daily restorative. But if you're asking them to do it twice a day, 3 times a day, 4 times a day, as opposed to 20 or whatever, like, they'll love you. That will not stress them out at all. In fact, it'll be far more interesting to most of them. Like in my office here, there are like 2 assistants that do not want to see blood. And the rest of them are like, that's cool. Can I sit in on that one? And it's like, it's not for everybody, but it's most people prefer to be chairside on something like that, because from the assistant standpoint, newsflash, fillings are just drudgery. Like, it's just daily, like, it's the case of the Mondays. Like, we're just doing nothing but class 2s all day. But then when you get to like watch a cool implant surgery, you feel like you're in it and doing like really neat stuff, because you are, like I mentioned earlier, like, it's hard to change a life with fillings. It's hard not to change a life with implants. Like, it's just way more excitement is happening, bigger things are happening. And so I find that the assistants get more interested and involved. So that immediately, like, your daily morale is a little higher there. You're doing fewer things, but with a higher market and like higher margin, higher revenue in general, higher draw to differentiate you from people down the street. So you can offer more surgical services and do less and less or fewer and fewer of the restorative stuff. It shouldn't be that you're trying to jam this into your schedule. It should be that you're trying to open your schedule up to allow more of that, because each one of those is so much more valuable than all the little piddly restorative appointments. So if there's concern there, it means you just haven't actually tried to implement it yet, because it does not take a math genius at the end of the day to be like, holy smokes, we produced 15K today on like 3 patients and it was like chill, as opposed to like, oh my God, we're running around like our hair's on fire when we got like $7,500. It's like, let's do more of the 3 patient chill 15 grand days. And like instantly, like your office is booming. In the implant courses, I think especially Igor, Dr. Borisov, he teaches a lot of the 3D printing kind of digital aspect. I do a ton of that stuff in my office. That I highly encourage everybody to get into. It's one of the most just immediate return on your investment kind of things. Even if you're not doing surgery, just getting into 3D printing and digital scanning, it just breaks all sorts of barriers and glass ceilings and things. And from the revenue perspective, like what are hidden revenues that you can find from taking our courses? If you implement that kind of stuff, everything that was like the slow bleed stuff that you send to a lab that's like, oh, that was like $200 there and $150 here and $75 there. And like you're waiting for a week and a half to get your custom tray back for your denture or whatever. Like nowadays, it's so easy to find online designers, even if you have no idea what you're doing. Like if you can capture a record, have the sales rep teach your 22-year-old assistant how to do it, she'll pick it up or he'll pick it up in a heartbeat because they're 22 and they're born with technology in their hands, and it doesn't matter if you're 62. That also engages your staff. They feel more important because they're the ones that know how to run the thing. Meanwhile, you're like feet up on your desk drinking a cup of coffee while they take your impression for you. You can send it off via email or Dropbox or whatever. Some designer whips up a thing and you 3D print a duplicate of the denture that the patient walked in with, which now is a perfect custom tray, an easy occlusion rim, and a wax try-in, all in one, free to the sense of like the resin required to print that's probably like $2. And that would have been a total of $400 to get a custom tray, an occlusion rim, and a wax try-in, all of which would have been like a 2-week wait in between each one. And instead I can have like a 25-minute wait or a 2-hour wait where I'm just like, hey, Mrs. Jones, like I know you need a new denture. It's 10 a.m. or like it's 11 o'clock. I'm going to go ahead and scan your denture. Could you come back and go have lunch and come back? And I'll see you this afternoon. And in that time, I've duplicated her denture. She comes back. Again, that should have been a 6-week wait, 2 weeks to do all these things that I would have now spent $400 and I spent $2. She comes back in. I take photos, do whatever little measurements and whatever, and say, cool, like we'll see you next time with the final, and which I can 3D print for, again, $20 or whatever, and have it for you literally like tomorrow. It's like, okay, I've just done a massively improved workflow. The amount of hours out of my chair, the amount of overhead, those things have plummeted. So therefore, like my hourly, your APPV or your average production per visit is a very important measuring stick in your office of like what you're doing every day. Is it worth it kind of thing? And are you trending in the right direction? That skyrockets. So you can make so much money off of just using 3D printers for small stuff like that, much less surgical guides. Like every implant in my office, I make a surgical guide for. I may or may not use it. I certainly have it there, but it's one of those that I just because I'm capturing their data in my intraoral scanner, my implant planning software is on the same laptop. I just map it out just so I know which implant to order or which one to get out of the drawer or whatever. It also makes me think through the surgery in advance. And so I send in my printer and it takes like 20 minutes and $20 kind of thing to make it, but I'm charging the patient $250 for it. If the implant surgery is actually difficult, or if I want to be sure of something or whatever and I want to use it, wonderful. If not, I've already gone through all of the thought process and I leave myself little love notes on the little report that I print out right then so that I can just wash it from my mind, not think about it. And when I call it Zen dentistry, I try to not know what I'm doing tomorrow because I wake up at 2 a.m. and I'm thinking about every step, even if I don't need to. I try to not know what I've got on the calendar tomorrow because I do my homework in advance, And so when I come in, I'm just like, what are we doing? Oh yeah, got the report. Okay, we're doing number that. Okay. Oh, right. Yep. Okay, let's go. And I just jump in and do it. But they've paid $250 for something that just made me already better at the procedure because I thought through it so thoroughly. I'm prepared with a guide if I want one, and it's just that quick and easy. And also patients like to know that you're doing it. Like I can't tell you how often I have people come in and request guided surgery because it's out there. They know about it. And it's like life is on the line for you bowling a strike. They want you to put the bumpers up, even if you're a professional bowler. Like, it's just like, why not? It just makes you safer. Like, it's hard to screw it up badly, So patients love it, and it's an easy revenue generator. But all things 3D printing, as far as my other courses go, like the sinus grafting course, back to a previous answer, in case these aren't in quick succession, like if you do bilateral sinus lifts and 2 bridges, that's a $25,000 plan versus an RPD, which is a $2,500 plan. Like that is, talk about a hidden revenue source. Like it's just the treatment that you can offer is a 10x increase sometimes just by being able to offer one additional procedure. So, there's a ton of stuff in the 3D printing world, but from a surgical standpoint, that's just going, again, like it elevates you from offering 1970s gold standard at best, which is a bridge, versus today's gold standard, which are implants. One piece of advice I would have to people who are debating about kind of taking the next leap into complexity of surgical cases and courses that we offer, I feel like people sell themselves short on how quickly they're going to achieve their goals, most likely. I feel like the people that are taking our courses are usually go-getters and kind of high achievers to where there's a reason they're there. They're not content doing fillings all day. And so you're obviously, as an attendee, already a forward-thinking person, but a lot of times it's hard to envision yourself being masterful at something that you don't have any background in yet. When we all started dental school, none of us knew how to do any of it, right? And it's very daunting because there's so much stuff we don't know, and we don't know how to hold our hands or sit or use a mirror, much less like any of the other things that are going into it. But that learning curve is so steep because there's so much to take in. At this point, they know how to use their hands. They know the anatomy. They understand the whys, and their hands will do what their brains are instructing them to do. That's a ton of what's actually required. It's just now picking up some new details and just becoming a little more comfortable with what's kind of beyond the gums a little bit. But it doesn't take too many reps to realize that, like, you can do it. You can totally do that. Holy smokes. Like, laying a flap and putting in one implant was actually a lot easier than doing that molar endo that you did on like your lunch break on Thursday, and it's like they every day do more complex stuff than they realize. When the goal seems so incredibly hard to reach, it's daunting, and like you sell yourself short that I couldn't do that or whatever. But really, back to the fundamentals thing, once you learn the fundamentals, you rearrange them, and to do the next level up, the increments are not as big as they seem. Like they're actually getting closer and closer together to add complexity, because it's once you're in the game, the next step is right there, kind of thing. It's just the difference between restored dentistry and surgery is a big one. Once you're in it, the next step is not far away. I think the biggest misconception is that the price tag isn't worth it, in the sense of like a lot of courses that are worth it are expensive, meaning like $15,000 to $25,000 for a few days of education seems extreme until you think about if you use it at all. Like if you take one course and you end up doing one full arch, now it's a push. Like it's a $25,000 course, and you go home and do one arch, and you made 25 grand, and now you're in the game. It's paid for. It's like you got your money back and you've lost nothing. You're going to do more, and then it's just boom, 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 boom. And full arch is just an easy one that it's probably about the same as a course. But an overdenture would be the same thing. Like if you take a $15,000, $20,000 implant course, if you learn how to put in some basic implants, you can make an overdenture. That's, between 10 and 20 grand, depending on what kind of practice you are, what part of the nation. Any single implant, like the last tooth, if there's nothing back behind it, every single one is just not a partial denture, and each one is like the equivalent of the full cost of a partial denture. And so if you put 3 implants on one side instead of making one partial denture, that's like 3x the partial. It's like you just had a $7,500 plan instead of a $2,500 plan. Like, again, you just increased by $5K. So like 3 of those patients will have paid for your course. And also like your assistants, again, will love their work more. And like your daily work will be more fun and all that kind of good stuff that we've talked about. If you do it at all, you get your money back hand over fist so quickly. And if you're not going to do it at all, then what are you doing taking the course? It's a bummer. It's sad when people report that they haven't done anything when they go back. So rare. We're all going to take courses where we go home, we're like, whoa, that is not for me. But you miss every shot you don't take, like you got to go out and take a course, see if it's something that's interesting to you. And if it's interesting enough to you to pay 20 grand to try, you probably already have a pretty good idea that you were pretty interested. When I first talked about what made me want to do Pathway, altruism came up a lot, because truly every mentor gives so freely of themselves, where every course see people giving out cell phone numbers and email addresses and inviting people to come visit their offices or stay in contact or whatever. It is a rare day that I don't get a text from at least one previous attendee about something, and it's usually celebrating a recent case. Look what I did today, Dr. Currie. Like, check this out. What do you think? Whatever. And they're almost always just really excited, and they want to share it with me because they're not doing fillings and they love it. They're giving back to me what I need. If I know that they're out there having their trajectory raised and their cannonball is flying further because we've met, that fuels my fire. That puts wind in my sails and makes me want to go back and teach the next round. But I think that I'm not unique in that. I think that every mentor there is doing similar stuff that I am. And so I don't know of any course that I've ever taken that offers contact information to mentors where we actually mean it. Like, you know what I mean? Like, where a lot of times you'll get an email address on like a title slide, like, hey, email me if you got any questions. Like, that guy doesn't want to. It's very much a community. Like the Implant Pathway community is very real. And they do a great job of doing kind of like annual or semi-annual symposium kind of get-togethers where they invite all previous attendees from courses over the years to come back to do events and stuff. And they're so fun. Like, they're really just heavy education, but just heavy on the fun. And they do an amazing job of that and creating where you kind of don't know who anybody is. Like, the very first invitation Moody gave me, he's like, we're actually doing symposium. This is about 4 years ago or so. He's like, we're doing a symposium in a month or two. Why don't you come out to Arizona and meet the crew, see how we do stuff, see if it's your vibe? Because we just had this awesome dinner where he and I hit it off. But I was like, I would love to do that. Let me go. I walked around all day introducing myself to people that were like, cool, which course did you take? I'm like, oh, do you work here? Like, no, but like, I think that guy does. And like, everybody I walked up, like, no one differentiated themselves as like mentor or whatever. We were just all hanging out. It was just a giant room of people hanging out, because it wasn't like we're smarter than you, we're better than you, whatever. Like, the approachability couldn't be more approachable, because no one could identify each other as anything but just part of the community, and I think that's unique and really neat. And the attendees thrive on that because they want to know that they can be you when they grow up. They want to know that you're just a guy or just a lady that they can see themselves in. They like started this journey not that long ago and got to a level that they would love to achieve at some point, So just the community and the accessibility, I think, is unique to Implant Pathway and is extremely special.